Prasad Naidu, Dr. Ashwin Tumkur.
Good afternoon, everybody. And after this wonderful ceremony of inauguration, I will be talking on something which is very novel and continuing with where Dr. Srinivas left in newer modalities of treatment for structural heart diseases. TAVI, we all know, everybody is excited about it, and our Hyderabad city is also not lagging behind. But this is something which is novel, but it has not picked up the pace and the enthusiasm with which it started because of certain limitations and certain issues which came up during the implantation of all this thing and the outcome of some of the trials. I will be taking you into brief about what exactly it is and how it is being done. There is a lot of trial data, little controversial, little favorable also, but what my whole impression is will be to tell you how this procedure is being done. Why this thing came? I think in the initial talks, Dr. Padmanabhan spoke about what are the alternate modalities we have for atrial fibrillation. Because it's a disease which is taking an enormous proportion in whole world. And if you see, almost 1.5 to 2% of general population is suffering from it. Only thing is we don't realize and we don't know whether we are suffering from it. Patient will be having just palpitation and he will not even realize that he has a atrial fibrillation. And you do a Holter, you may not pick it up. But newer way of long-term loop recorder and all this thing, and you may pick up that yes, patient might be having a paroxysmal AF and subsequently he is going to go into a permanent AF. Now, if you see, almost 33 million individuals over the world are suffering from atrial fibrillation. And it is the second most common etiology for stroke, and which is such a disability for causing disease. So if a person develops stroke and it is such an innocuous disease, atrial fibrillation, then something has to be done. And to prevent a stroke, people tried with vitamin K antagonist, and then subsequently because of bleeding issue and non-compliance issue, they came up with novel oral anticoagulants. But because of the cost issue and other factors, it still has not picked up also. But if there is a patient who has got a bleeding tendency or who is on multiple antiplatelet, what options we have? Can we reduce the bleeding risk in these kind of patients? So that is where an alternate treatment modality was required. Now this is what we do when we decide whether a patient needs a anticoagulant, and we try to balance whether the patient has a bleeding risk or not. We try to evaluate the CHAD-VASc score. Initially we had CHAD score, now because of the other factor, we also now came up with CHAD-VASc score, which basically a point system where we take into account heart failure, hypertension, age, diabetes, stroke, vascular disease, and what is the sex of the patient. And at the same time, we also calculate what is the Has blood excrete. That means what is the tendency of this patient to bleed if we are going to give him anticoagulation. So we try to strike a balance between the two and then choose a modality. But if everything was so rosy, everything was so good, then what was the need? If you see 30 to 40% or 50% of patients, they don't receive oral anticoagulant because either there is a contraindication or there is a bleeding or because of patient preference or there is a physician who may not be very comfortable with it. If you see, even if the patient is put on oral anticoagulant, there is a 2 to 3% lifetime risk of major bleeding. And if you don't, there is a risk of ischemic stroke. 1/3 of patient on warfarin, the INR doesn't even reach therapeutic range. So even if the patient is on drug, it is not working. There is a very high rate of discontinuation with this drug. And it is said that almost 40% of patients who are at risk of stroke, they don't receive any anticoagulation. And this leads to a residual stroke risk of almost 2 to 5%. Now, if you look at the bleeding risk, if you give only monotherapy with warfarin, aspirin, clopidogrel, and you go into triple therapy, you can see gradually the risk is increasing one by one as you add the number of antiplatelets or anticoagulants. Now, if you look at the compliance, even after a stroke also, if you see, the poorest drug which has got the least compliance is the oral anticoagulant. So, that is where, is there any way we can obviate the need for this? Now, when people try to analyze, this is a very interesting slide because of which only the whole concept changed. They had almost 17% of patient, out of this they found that in the non-rheumatic patient, 1% was due to the clot in LA and 16% was, that means a total of 94% clot was arising from the LA appendage, and that is where the concept of LA appendage closure came. This is something not new. This LA appendage closure has been going on from years together. When our surgeon used to take the patient for mitral valve surgery, they used to close the appendage because they know that is where the clot is arising. And when we do a TE for BMB also, we know that majority of clot is in the LA appendage. But non-surgical closure picked up after the first LA occluder was done in 2001. Now, if you look into the history, what they found is the electrophysiologist less. When he was trying to do EP study, he was finding that most of the time his catheter was going into the appendage without much of difficulty. And this led to the concept of occlusion. And in 2001, Haas Sievert, along with Les, they did the first LA appendage occluder using a plateau device, but the device was very cumbersome and then the device had to be withdrawn. But subsequently, it was Bernie Meyer who was a leading person who actually did LA appendage occluder using a ASD device, ASD PFO device, and subsequently it was modified into ACP device, and now we have got the amulet device. And in 2002, a different type of shape of the device, that is the Watchman device, came into practice, and the major trial and major data is with this Watchman device. Now, this is how a Watchman device looks, and this is how a ACP device looks. They are pretty simple, but only thing is the ACP device is very short device. And it is almost like a PFO device with a short neck and two discs which are there. These are some of the other devices which are available in the market, but in India we used to implant mainly the ACP device, but of late the Watchman has also come into picture. Now, why we were doing LA appendage closure? Because as we know, 90% of thrombus is in LA appendage, and currently in the European guideline also it has been given, ACC/AHA guideline also it has been given as a class 2B indication. What is the evidence we have? I will not go into the details of all this thing because it will take a lot of time. The two major trials which led to the approval of this device was the PROTECT and the PREVAIL trial. And the PROTECT trial had almost 800 patients and the PREVAIL had almost 400. But the largest trial, the registry which was done was with Evolution, which was a registry of all the patients who are taking part in the implantation of Watchman device, and that was the Evolution trial. And this is some of the trial data with ACP device. We have international registry, European, Asia Pacific, Latin America, Polish, Canadian, some 40, 50, 60 like that. But as you see, the major volume of data was with the Watchman device. Now, the major issue with these devices was whether they were safe or efficacious or not. So safety and efficacy was the primary concern. And when they analyzed the PROTECT data, what they found that the initial half, when the operator was not very experienced, the event rates were high. But when they went into the second half analysis, when the operator became more experienced, the event rates were almost half. So from in the first half it was 9.9%, it came down to 4.5%, and in the recent CAP2 study it was almost, so it is hovering around 3 to 4% right now. If you look at the mortality, because of this initial problem which happens during the procedure, subsequently you can see the curve is diverging. Because oral anticoagulant, the bleeding risk will remain as long as the patient is continuing with the, and as the age advances, the bleeding risk and other comorbidities come in, the bleeding risk will keep on increasing and increasing. But once you have implanted the device, there is, except for this initial period, subsequently there is not much issue with the device. So that is why you can see in the late stages that the curve is almost changing. Now, when you implant the ACP device, the data is almost there. They have reduced the effective stroke rate by almost 50 to 60%, and the bleeding risk has further reduced by more than 60%. Now these are the trials which compare, there is no head-to-head trial comparing this device with newer anticoagulant. So they analyzed the historical data and tried to compare it, and this is just a comparison, and this is just a initial conclusion which was derived from this type of analysis, which may not be very accurate. They said that novel anticoagulants are superior to warfarin, and the device is a reasonable non-inferior alternative to warfarin, but cautious use is essential given the safety concern of the population in regards to the bleeding risk or procedure related complication because of the lack of published data in the device group. So I'll tell you a little bit because of the time constraint. In India also the first experience came from Ranjan Shetty. And when we do the implantation, the most important thing to be looked into is the transesophageal echo, because that is where we try to analyze how the appendage is, what is the size of the device to be taken. So we are all familiar with septal puncture, and when you do a TE, you have to take a TE in two multiplanes, and one is 0 degree, and then you go to 45 degree and 135 degree, and then subsequently you try to analyze. You take basically two planes. The first plane is basically this one, where it is from circumflex artery to the ridge, which is actually the mouth of the appendage, and you go 1 centimeter below, and that is exactly where the bulb of the device will fit in, and that is where it will anchor, and this is the where it will close it off. And under TE, we do the septal puncture, and you can see this septal puncture is going on. You have to do posterior and a lower inferior puncture so that the device just goes up. The sheath is pulled up, and you can see a tire shape of the distal bulb, and once you are satisfied that it is hooked properly, you do a tuck test. Here you are doing a tuck test, and then you release the device other part also. And once it is done, the patient is given aspirin, but if you are using a Watchman, they say minimum 6 months anticoagulant is to be given. The possible complications are perforation, or there may be effusion, there may be device embolization, thrombosis, but very rarely if you are not a proper operator. This is some of the cases. This is if you have put a stent in circumflex, you can make out where the device origin has to be there. It should be 2/3 beyond it. And
Dr. Purohit.
Yeah, it's over, sir.
Yeah.
It's over. This is how the device is being deployed, and this is some of the cases we had done. You can see the device is implanted properly, and then there is a tuck, and then in conclusion, the L impedance is a promising modality which is developing fast, but it needs an operator experience to achieve better outcome, and patient selection is of utmost importance.
Which is mainly concentrating on the different age groups and the sex where the CHD is prevalent. The red is represented by the female, and blue as a male. As the age increases, the incidence is increasing in the both, but if you see the percentage wise, there is a definitely increase in more in the females. And of course, the incidence of angina pectoris by the age and the sex. In the males, it will present more as an anginal episodes. In the females, anginal episodes are not frequent. I will show you a slide where the atypical presentations are much more frequent. In India, especially in the men, the incidence is about 4.8% according to the 2016 study, and in the women it is about 2.6%. And the DMAT registry and ACS registry has demonstrated that 21% were the women who are suffering with the presentation as an acute coronary syndromes. And another study from the Ahmedabad also demonstrated that 17% of the females are suffering with acute coronary syndromes, especially these patients are having a higher incidence of the hypertension, diabetes and the obesity. The average age is slightly higher for the females when compared to the male, and the females has more comorbidities, and females present late to the medical attention, and women are referred less often to the appropriate testing or the treatment. This is about a decade back. Nowadays, most of the cases are referred very well, but the management is not proper, even though the many studies have demonstrated that either the PCI or the CABG is equally efficient in the female when compared to the male also. But still, the treatment component is not implemented as effectively as expected. The women with MI are more likely to have a complications and increased mortality. This is mainly because they are recognized at a later stage. Young females with MI have a worse prognosis than the men. Obesity, the prevalence is the same in the men and women, but the risk of the CAD is 64% in the women when compared to the 46% in the men. And the fewer women has been included in the studies, even though the already ICMR has coined definite statement saying that 33% should be included in all studies, the women should be included, but it is less implemented in many studies. Among the individuals with the premature in MI, women experience a twofold higher mortality than the men. There is a definite difference in the pathophysiology of the CAD in the women when compared to the men. Whereas the plaque ruptures are the much more frequent in the men, coronary spasms are the much more frequent in the female. Which was previously thought to be the benign is now proved to be not at all a benign. The men have the higher degrees of heteroma and endothelial dysfunction, where the females has the disease of the microvasculature. The retinal artery narrowing has been shown to be a marker for the microvascular disease in the women, but not in the men. So as this slide shows, the women will present with atypical symptoms much more frequently, like unusual upper body discomfort, shortness of breath, breaking out the cold spike, an unusual unexplained fatigue, nausea, and lightheadedness. In 43% of the cases, according to the NRMA registry, there is no chest pain when the patient first time presents with an acute MI in females. The symptoms are also, the women who presented without a chest pain are much sicker and has a worse outcomes, and more had the diabetes and the later presentation, as I already mentioned previously, and less likely to receive the treatment. Even medical treatment they receive less frequently, less intensively, lower doses. The diabetes, as we already know, this increases the risk as well as in the women and the men. It is in the women it is about 3 to 7-fold. Only it is rates, and according to this less than 12 years, and gestational diabetes, preeclampsia, OCP usage, and the early menopause, all things are additional burden to the women which are predisposed for the coronary artery disease manifestation. Under treatment of the CAD, there are the very many studies which are represented that the under treatment is very common in them, and because of the under treatment, the risk of the recurrent MI is also increased. And another added burden to the female is the peripartum period. During the pregnancy, that is especially third trimester and 6 weeks postpartum period, they are prone for the development of the coronary artery disease. This is not just because of the coronary dissection. ACS in pregnancy, it's about coronary dissection is a common, and followed by the coronary atherosclerosis, and coronary spasm will be superadded on that. Of course, the management will be the similar to that, but the fibrinolytics are there is a controversy, and it is better not to do it. And of course, the diagnosis of the myocardial ischemia, we can't use a treadmill test to know about that, as we already know the sensitivity is very less. So exercise SPECT may be the better, and pharmacological echo when compared to the other modalities is better. And the abnormalities on the late gadolinium enhancement consistent with an ischemia. So the MRI nowadays is emerging as an important tool to know the ischemia. Of course, all the females are not having an obstructive heart disease. Nearly 40 to 45% of the patients who are presented with a significant typical symptoms are going to have a non-obstructive CAD. But adenosine CMR will quantify them whether they are high risk or not. According to the WISE study, abnormal stress-induced CM in this in females. Of course, the IJCD journal is especially Indian Journal of Cardiovascular Disease in women is especially started mainly to concentrate, as there is no statistics are available for us to know about the women heart disease especially. The take-home message is CAD is the biggest health risk for the women. Women can present differently, mainly without a chest pain. So we have to pay attention with an atypical presentations. Screening program should be then encouraged. And please, I request all of you to go to our website and see the importance, how much importance we have to give to really to treat a female who is suffering with coronary artery disease. Thank you.
Call the next.
No, he's not there. That's one.
Okay, Dr. Sridhar, do we have any time for questions or?
Sir, time is very less, sir. Next session, sir.
Okay,
Thank you, sir.
okay then, thank you.
Thank you, sir.
Thanks
Thank
to
you.
all the speakers.
Thank you everyone, sir. Let's move on to the next session. I would like to invite chairpersons Dr. V. Daisagar Rao, Dr. Sarat Chandra, Dr. P. C. Rath onto the dais. And the topic is Professor P. S. Rao oration, Caring for the Rural People, by Dr. Patriya Bidinger.
Dr. Y.V. Subbareddy garu, please introduce about Dr. Patrika Badingar. Thank you.
Good morning. Dr. Patricia came to India with her husband, Dr. Fran Bidinger, and their young son Joel in 1977. She obtained her BSc from the University of California